Today we're going to be looking at the anatomy and pathology behind rotator cuff tears. My name's Andy. I've done this with the help of my colleague Greg, who's another final year medical student with an interest in sports medicine. The main resource that we've used for this is the Stanford Medical Journal, which I'll leave a link to in the description. It has a really good resource on shoulder examinations. So let's start with a little bit of anatomy of the joint. So the bones that make up the shoulder joint, also known as the glenohumeral joint, include the scapula, the humerus, and the clavicle. So as you probably know, there's multiple ligaments, tendons, and both deep and superficial muscles that also aid in movement of the shoulder joint. However, for today's video, we'll kind of forget about the ligaments and the tendons and focus on the four muscles that are collectively known as the rotator cuff. So the rotator cuff muscles help to stabilize the joint and aid with movement in almost all of the directions. We'll go into a little bit more detail about the individual muscles. The first one, and perhaps the most important, is the supraspinatus. Now I say this is the most important because it's the most frequently injured. So this originates from the supraspinous fossa of the scapula and attaches to the greater tubercle of the humerus, where 3 out of the 4 rotator cuff muscles attach. It's responsible for the first 15 degrees of shoulder abduction. Secondly, there's infraspinatus, which originates from the infraspinatus process on the scapula and also attaches onto the greater tubercle of the humerus. And this, along with Teres minor, the third muscle, is responsible for lateral rotation of the arm. As I mentioned, the third muscle is Teres minor, which originates from the posterior scapula and attaches again onto the greater tubercle and is responsible for lateral rotation. The final muscle is the Subscapularis, which starts in the subscapular fossa anteriorly and attaches to the lesser tubercle of the humerus, and that's responsible for medial rotation of the arm. So now that we've discussed the anatomy of the rotator cuff, it's important to think about what kind of a history might make you think of a rotator cuff tear. So tears tend to happen following acute trauma, so be that traction, dislocation, or heavy weight-bearing exercise. In the acute phase, there'll obviously be pain over the shoulder, and a key differentiator from other types of shoulder pain is there tends to be pain over the lateral shoulder here. Now, that's important because 3 out of the 4 rotator cuffs, as we previously mentioned, attach to the greater tubercle, which is found about here. Now, rotator cuff tears also tend to occur with weakness, particularly of abduction for the first 15 degrees. Again, this is because supraspinatus is the most commonly injured. Now, chronic rotator cuff tears might also present with kind of aching in the deltoid and deltoid fatigue. Now, this is because it's having to compensate for the weakness of the abduction of the rotator cuff. And perhaps most importantly is the fact that active movement is painful and reduced, but passive movement remains and is not painful, and this is a key differentiator from things like dislocation and impingement of the shoulder. It's also important to note that rotator cuff tears often present together with more than one muscle being torn. So now let's move on to examination of the rotator cuff and trying to work out which of the muscles has been torn in order to guide treatment. So as we previously mentioned, the supraspinatus is the most important to examine, and this can be examined doing the empty can test. So this is when you get your patient to lift their arms to 90 degrees and then 30 degrees forward in flexion and pretend they're emptying a can, so pointing their thumbs down to the surface. If you also press down on the arms, any pain on the ability to keep the arms up is also indicative of a supraspinatus tear. In the examination, you'll also note that there might be some weakness on the first 15 degrees of abduction of the arm. Now, secondly is examination of the infraspinatus and the teres minor. And clinically, these are very difficult to differentiate. If you think about the anatomy, they both originate from the same area, and they're both responsible for lateral rotation of the arm. So to examine these, you do external rotations against resistance. So you get the patient to bend both their arms to 90 degrees and attempt to externally rotate whilst you apply resistance. Again, pain on this is indicative of a tear of either the infraspinatus or the teres minor. Finally, there are 2 main tests to check for the subscapularis. So there's something called the lag sign, which is where you ask the patient to place their hand behind their back, and if they can actively keep their hand off their back, then this is a negative lag sign. Whereas if it's too painful or too weak to actively keep their hand off their back, then this is a positive lag sign. The second test is what we call the Gerber's lift-off test. Excuse my pronunciation, it might be Gerber's. Which is where you ask the patient to again lift their hand off their back, and then you apply pressure on it and see whether the pain occurs. If there is pain, then this is still indicative of a subscapularis tear. So this is one of those scenarios in which the clinical examination is really important. And again, this is taken from the Stanford Medicine website, so be sure to check that out. But they have a quote that says, "If a careful exam does not elicit significant pain or laxity, imaging studies are extremely unlikely to provide further useful information." However, if there is pain or laxity, then the next study that you want to do in acute setting is an X-ray of the shoulder joint, both lateral and anteriorly, just to check that there's no underlying pathology such as fracture or dislocation. If the X-ray comes back normal, further imaging modalities include an MRI or ultrasound, but this will more be guided by the orthopedic team. The main takeaway messages from today's video are to suspect a rotator cuff tear when there is reduced and painful active movement, but passive movement is still preserved and non-painful. And to remember to do the empty can test, resistance to external rotation, and the lift-off test in order to test the 4 different muscles of the rotator cuff before referring on for further imaging.